can get anytime on IUSG website. As usual, you will receive an email at the end of the course to apply for the credit hours, and the certificate would be sent. Please type your questions in Q&A, and we will be answering them in real time as in when we receive the questions, because the later slot is left for the controversies. With this, I would request John Campen, who is the chair of the Education Committee, to start the program. And there is some change. Dr. Mamta Agarwal will be second speaker. She's delayed somewhere in the traffic, and Massimo would take up the first talk. Over to you, John. John, you're muted. Well, I think, John?
I don't.
Yeah.
But I have a weak connection. Let's see.
Okay. You want me to carry on?
Okay. I have a kind of weak connection today. So if you don't hear me, then
okay, John, I think
welcome everyone. And because of some logistical changes, our first speaker will be Massimo Accorrente, who is a world-renowned uveitis specialist and faculty at South.
Well, I think John has a problem with his connection. So we go on to our first speaker of the day. That is Massimo. Massimo is going to talk about the clinical exam, investigations, and imaging in patients with uveitic edema, glaucoma, and this will be subsequently followed by Mamta's talk. Over to you, Massimo.
Okay. Hi, everybody. Can you see my desktop, the slides?
Yes.
Okay, dear colleagues, thank you very much for joining us in this very interesting webinar on uveitic glaucoma. I will speak about the clinical examination, investigation, and imaging in our patients. So as Mamta maybe will tell you later, a combination of partial angle closure, partial open angle, with damaged trabecular meshwork and partial steroid-induced and smoldering inflammation, all these findings can markedly elevate IOP. And the definition of IOP glaucoma is raised intraocular pressure in a patient with uveitis with diagnosed with optic nerve damage causing typical progressive visual field loss. On the other hand, uveitis-related ocular hypertension is the definition of a patient with the glaucoma with an increase in IOP above 21 millimeter of mercury. We can, as we all know, we can have two types of raised intraocular pressure in patients with uveitis. The first is during the acute phase of uveitis, and the typical findings are those of viral uveitis, toxo-retinochoroiditis, in which almost 35 to 40% can develop a raised intraocular pressure, Boca-Nagarata disease, when you can have an angle closure because of the ciliary body rotation, and the pupillary block in patients mainly with recurrent uveitis when extensive synechia have been formed and can cause a pupillary block. The most of the patients who developed IOP raise in uveitis are those from chronic or recurrent uveitis when progressive damage of the trabecular meshwork can be found, and also the formation of anterior as well as posterior synechium. Which is the difference between primary open-angle glaucoma and the uveitic glaucoma. There are mostly three. There's the time of discovery, that usually earlier in the patients with uveitis than in glaucoma. The age of the patients, which is very important, as we will see later, because younger people are supposed to have a stronger optic nerve that can withstand the high pressure for a more extended period of time, while older patients, as those with glaucoma, develop severe optic nerve damage even during shorter interval of IOP rays. And this is particularly important in elderly patients with uveitis. The third difference is the need for additional therapy. On the left side of the slide, so you can see that is coming from the MASS study that has demonstrated that more than 50% of the patients with uveitis and with a follow-up longer or up to 10 years can develop a raise in intraocular pressure higher than 21 millimeter of mercury. And 25 to 30% of these patients will develop a raise in intraocular pressure higher than 30 milligrams. On the right side of the slide, you can see how the therapy that we usually use for treating patients with uveitis, that is corticosteroid, can affect the raise in intraocular pressure. And as you can see, while you give a patient a daily systemic prednisone less than 7.5 milligrams, you can have a hazard ratio of 1. But if the daily corticosteroid therapy systemic is up to 7.5 milligrams, you can have a hazard ratio of 2. And on the other hand, you can see how the number of corticosteroid eye drops from 1 to more than 6 can increase the hazard ratio, as well as the periocular and intravitreal, and of course also fluocinolone implant. So everybody knows that we have some tools that should be considered essentials in the definition and the follow-up of the patients with the glaucoma, uveitic glaucoma. The first is a slit lamp, with mandatory just to assess it, to define the type of uveitis, the form of uveitis you are facing with, anterior, intermediate, posterior, or panuveitis. And it's also necessary to assess the amount of inflammation we have to treat, and this will be addressed by Peter McCluskey's lecture. Then tonometry is essential to know the level of IOP we have to control. Gonioscopy will let you tell if you are faced with an open angle or a closed angle. And visual field analysis can differentiate between patients with uveitic glaucoma or patients with ocular hypertensions. Additionally, the visual field analysis is important to look for changes or progressive visual field loss that may need some changes in the therapeutic approach. These are some other useful tools that can be suggested in patients with uveitic glaucoma. And this is the non-contact tonometry if you have some infectious problem with your cornea, or the pachymetry, either contact or non-contact. And we will see later which is the relationship between the corneal thickness and patients with uveitis and hypertension. And finally, of course, the NFL analysis with OCT that can detect, it is able to detect, especially in primary open-angle glaucoma, some preperimetric changes, and that can be used with some limitations, as we will see later, also in patients with uveitic glaucoma. Additionally, if you have problems with the visualization of the angle with gonioscopy, we can go through an UVM analysis or an OCT of the anterior segment. So which is the role of corneal thickness? It has been demonstrated that corneal hysteresis as well as corneal resistance factor are significantly lower in patients with recurrent anterior uveitis. This means that the biomechanical property of the cornea is changed by the recurrence of uveitis, although it is not related to the severity of the illness and the course of the disease. It is important to know that corneal thickness can vary during the active or inactive phase of the disease. It is being demonstrated in Behçet patients. As you can see here, there is a significant difference between patients with active inflammation in Behçet disease and those with inactive inflammations, and this is statistically significant. And we have also a significant decrease of the corneal thickness in patients from the active to inactive form after treatment. So it means that if you would like to look at the corneal thickness to add another parameter to evaluate, which is the target IOP, and we will see this in the surgery lecture, you should keep in mind that you have to check the corneal thickness during an inactive phase of the disease. The same is for chronic uveitis, and one example is the Fuchs uveitis, when the corneal thickness is decreased in the affected eye compared to the normal contralateral eye, and also the angle is wider in the affected eyes compared to the contralateral eyes. Everybody knows the importance of visual field in the follow-up of patients with glaucoma. And this is a very interesting paper dealing with the rate of progression of people with uveitic glaucoma compared to primary open-angle glaucoma. And as you can see, the rate of progression is higher in patients with uveitic glaucoma. So we have said just before, the young people as this is the age for patients with uveitis can withstand for a more extended period of time even a high value of intraocular pressure. But on the other hand, uveitis people has been demonstrated that the rate of progression is higher, and the relative risk of being a fast progressors is the double compared to that of primary open-angle glaucoma. And the very important thing we will see later, that is if you consider the mean IOP of these patients, the patients with uveitis and the patients with primary open-angle glaucoma, the mean IOP is almost the same, but there is a wider range of IOP in patients with uveitic glaucoma. And this is another example of one patient with a combined disease. This is a patient with a normal tension glaucoma, both eyes, and an anterior uveitis, CMV anterior uveitis in the left eye. As you can see here, you can appreciate that there is no significant changes in the cupping disc of these patients in 2 years. This is the eye with only normal tension glaucoma, while there is a progression in the visual field dose. If you look at the other eye, and on the left side of the slide, you can see the typical endothelial precipitates of a patient with the CMV anterior uveitis. Again, the cupping disc is almost the same, and we detect a progression in the visual field loss. This is the patients with a IOP lower than 12 millimeters of mercury. Even if you measure the pressure all over the day, he is on medical therapy. The problem is that his corneal thickness is 486 microns. So you should keep in mind that in this particular difficult case, you have to catch all the possible information on the status of the patients in order to look at the proper IOP of these patients. And we can just demonstrate this as a further demonstration of the importance of the target IOP in patients with uveitis. That should be less than those usually considered for glaucoma patients. Another important limitations on the visual field, especially in detecting any visual field loss over time, is the progression of cataract. As you can see here, this is a myopic patient with uveitis and the progression of cataract in 3 years. And it has been demonstrated by a study coming from Israel that there is a correlation of glaucoma's field defect, and this correlates with the presence of cataract. If you have a patient with clear lens, in those studies, they've not defined any field defect in all the patients, while if the patients have presented any degree of cataract, 50% of them have developed a field defect, and the difference was statistically significant. So OCT has been defined as a tool able to detect preperimetric changes in patients with primary open-angle glaucoma. But what about the patients with uveitis? We have some limitation, and I will explain you in the next 2 slides. This is a study considering the patients with uveitic glaucoma, hypertensive uveitis, normotensive uveitis, and controls. And it has been demonstrated that uveitis with normal IOP has a thicker RNFL measurement compared to the normal contralateral eyes. And in patients with active uveitis, normal IOP, no edema, at least clinically apparent, no absence of edema or disc swelling, they have also an increase in RNFL thickness. If a patient has been diagnosed with uveitic glaucoma, the RNFL is thinner it's a global RNFL is thinner, although a significant difference has been detected only in the superior inferior nasal quadrant, while the temporal one, which may be affected, for example, for a smoldering subclinical exudation, it is not so significant. On the other hand, hypertensive uveitis has been demonstrated to have a thinner RNFL analysis only in the inferior quadrant. And those authors are suggesting that this quadrant can be a biomarker of the damage of in patients with hypertensive uveitis. They have concluded the risk factors for glaucoma are older age, longer follow-up, the maximum IOP, and the increased IOP much related to uveitis than to the corticosteroid therapy, while the risk factor for hypertension are male sex and anterior uveitis. And this is another example of a patient with primary open-angle glaucoma, bilateral primary open-angle glaucoma, and uveitis in the left eye. She is a lady which is claustrophobic, so she cannot stand any visual field analysis, normal corneal thickness, 545, if I remember correctly, and a normal IOP, always lower than 70 millimeter of mercury in both eyes during the 5 years of follow-up. But what we have detected is an increase in the damage of the optic nerve during time. So why it may happen? We have considered 70 maybe a good target IOP for these patients, but we have to consider also that in patients with uveitic glaucoma, you can have diurnal spikes of intraocular pressure that are higher than those that you can detect in patients with glaucoma. This is another factor that you have to address properly. It has been recently proposed in patients with primary open-angle glaucoma that IOP are significantly related with the faster rates of ganglion cell layer, ganglion cell inner plexiform layer loss during time. And these authors have proposed this, the thickness of this the ganglion cell layer, ganglion cell inner plexiform layer as a biomarker for the evaluation of the fast progression of this patient. It is very important to approach them from the therapeutic way more properly. And what about OCT angiography? OCT angiography, this is the first report on the use of OCT angiography in a patient with uveitis. This is a lady, 33 years old, with a normal capping of the disc, as you can see in the left side of the slides. It's very few alteration changes in the visual fields, and the RNFL analysis showed a thicker RNFL in the left eye, that is the eye is affected by uveitis, compared to the right eye that is normal. And the authors went to an observation of the ganglion cell layer that was exactly the same in both eyes, either affected or non-affected by uveitis. But when they look at the vessel density, they found that there is a reduced peripapillary and papillary vessel density in the eye affected by hypertensive uveitis. This has been further addressed by another pilot study from Germany, who have demonstrated that papillary and peripapillary vessel density is lower in uveitic glaucoma versus normal controls, and also uveitis glaucoma versus uveitis with normal IOP, While the macular vessel density is lower in uveitic glaucoma versus normal controls, but is exactly the same in patients with uveitis with or without an increase or in intraocular pressure or glaucoma. Which are the problem with the angiography? As you can see here, these are the exclusion criteria of this study, and arterial hypertension, hypotension, diabetes, or other vascular disease that can affect the vasculature at the level of the optic nerve can change the type of vessel density at the level of the optic nerve itself. So it may be taken with caution all the information that we can derive from patients with uveitis. So to summarize, slit lamp is essential to assess the clinical findings, to drive to the proper etiological diagnosis, to quantify the amount of inflammations, and to decide on the type of therapy, medications, laser or surgery that is needed for your patients with uveitic glaucoma. Tonometry decides on therapy, on the level of therapy according to the IOP values, and can monitor the IOP changes. Gonioscopy check the angle situation and tell you if you are dealing with an open angle or a closed angle patient. Visual field analysis with all its limitations classify the patients into uveitic glaucoma or uveitis-related ocular hypertensions and can monitor visual field loss and the need for therapy changes. Pachymetry, you should take into consideration with caution because, as we have seen, there may be some differences between the active and inactive form or any active type of uveitis, but it is another additional parameter that should be taken into consideration to define the target IOP in this patient, which is very difficult. OCT and OCT angiography, although they've been able to detect preperimetric changes in patients without uveitis, and they can be useful in patients who cannot do visual field analysis for different reasons, are for sure well accepted by patients and preferred to visual field analysis that is too long, it's a little bit boring, but should need a further study to assess their if they are useful or not in patients with uveitis. Thank you very much for your kind attention.
I'm in the middle of something.
That's fine.
I think John again lost the connection. So it's me introducing Mamta again. Mamta, everybody knows. I don't have to introduce. Mamta is with SN and now moving to San Antonio very shortly. So Mamta is going to talk about epidemiology and pathogenetic mechanisms of glaucoma and uveitis. And there John is. John, would you like to say something? Okay, Mamta, we can hear. You have to go on slideshow.
Yeah, I can start. I'll
Yes,
put it.
please go ahead.
Good evening, everyone. Am I audible? It's clear.
Yes, Mamta, it's all good.
So I'll be talking about epidemiology and pathogenesis of the mechanism of glaucoma in uveitis. As we have all heard that it's a serious complication causing irreversible visual loss. The history, when I read about it, it dates back to 1831 when Joseph Baer, he described arthritic uveitis with glaucoma. And then in 1891, it was the modern classification of uveitic glaucoma, which was described by Presley Smith. Fuchs uveitis with glaucoma, we all came to know in 1906 and 1948, we were talking about glaucomatous crisis by Poshner and Schlossman. But when we look at all the studies in the literature, we find there is limited accuracy. Why? Because there's an inconsistent definition of glaucoma in all the studies. They're all retrospective studies, and most studies with complicated patients are done in the specialized clinics, tertiary care centers. And there's always insufficient power or frequency of the raised IOP in different uveitic entities. So what are the factors which cause IOP elevation? As we know, it's age, the location, type of uveitis. Is it a severe uveitis, chronicity? And then how is the appearance of the iridotrabecular meshwork, anterior or posterior synechiae, corticosteroid treatment, intensity, and the steroid responders. So looking back at the epidemiology, when we see the literature from the West, from US, there are studies which say that the uveitic glaucoma prevalence was 6 to 10%, whereas ocular hypertension was seen in 3 to 7% in uveitic eyes. But when we see on the East, the Japanese people, they said that it is nearly 50% that we see uveitic glaucoma, including 20% the glaucoma and 30% ocular hypertension. And a recent study done in Taiwan, it had, again, it's uveitic glaucoma and ocular hypertension 8.5%, whereas in the group from Thailand, again, described that nearly 50%. So we see that there's a lot of variability in the epidemiology. This is just a chart which shows the various studies and the range of prevalence of ocular hypertension and uveitic glaucoma. The MUST trial, as we all know, it describes what are the risk factors. The patients younger than 50 years have more propensity. Males, Black people, baseline use of IOP-lowering drugs, and also the patients who have fluocinolone implants, they are more prone for elevated intraocular pressure. What are the risk factors? It's an old patient at the onset of uveitis with a longer duration of uveitis. It is more commonly seen in anterior uveitis, and also we see it more in viral uveitis, Fuchs iridocyclitis, and Poschner-Schlossman syndrome. Coming to the pathogenetic mechanisms, we all know that acute uveitis, we see low pressure because of the decrease in aqueous production and increase in uveoscleral outflow. But it's a complex relationship because of the trabecular outflow, open or closed angles. It's a fluctuating aqueous secretion in uveitic eyes, and of course, the steroid response. So what do we see? Uveitic glaucoma, we have raised pressures. It's mainly because we increased trabecular resistance, which causes an imbalance between the production and the outflow. So then the first kind we know is open angle glaucoma. When it's an acute uveitis, there are inflammatory cells, proteins, and fibrin, which blocks the trabecular meshwork. The trabecular endothelium, it phagocytoses these cells and debris in the outflow channels. But excessive phagocytosis, it results in the cell migration away from the trabecular meshwork and thereby causing reduced cell density. And this hampers the trabecular function. But there can also be an excessive deposition of extracellular matrix in the trabecular meshwork. Trabeculitis, which is the swelling of the trabecular lamellae, as we see in herpetic uveitis, it causes constriction of the trabecular endothelium, and thus it reduces the spaces and increases the outflow resistance. Another mechanism of open angle glaucoma, what we know, the TM can be scarred, or the Schlemm's canal can also have scarring with loss of endothelium and functional cells, and then there is fibrovascular growth in the angle. Another mechanism of open angle glaucoma, what I came across is because of the breakdown of the blood aqueous barrier, it causes changes in the aqueous composition. There are increased cytokines. There is increased protein content, which increases the aqueous viscosity, and it also elevates the outflow resistance. How about corticosteroids? It also is one of the reasons of open angle glaucoma because it increases the aqueous secretion and reduces the outflow. It causes accumulation of glycosaminoglycans in the trabecular meshwork, and it reduces the phagocytic activity and also alters the TM cell size and the cytoskeleton structure of trabecular meshwork. The other mechanism we all know is angle closure, and main reason is what we see here is posterior synechia between the anterior lens capsule and the posterior iris. There is restricted flow of aqueous humor from the posterior to anterior chamber, which causes seclusive pupillae and leading to iris bomb. And then there is an extensive apposition of peripheral cornea to the iris and closure of the angles. It's an indicator that it's a severe case of chronic uveitis, can be seen in both granulomatous and non-granulomatous uveitis. Another mechanism is synechial angle closure. What is that? It's the peripheral anterior synechia because of the accumulation of inflammatory debris and the cells in the angle. And this pulls the iris towards the angle. A study by Takahashi et al., it shows that peripheral anterior synechia is seen in 50% of the eyes with raised IOP, and more than 180 degrees of the angle is closed. What are the risk factors? If it's a pre-existing angle closure, or if there is a pupillary block, or it's a forward displacement of the iris and lens diaphragm. What we know is we can see these in granulomatous, chronic, and recurrent uveitis. Angle neovascularization also leads to an angle closure because of the increased cytokines and like IL-1 and TNF-alpha, which we see in these patients. This is a very important mechanism where we can see an angle closure glaucoma when there is an anterior displacement of the lens iris diaphragm. What is that? Inflammation of the ciliary body. It causes anterior rotation of the ciliary processes, and there can be a ciliary body detachment. It's more commonly seen in Vogt-Koyanagi-Hardage disease, posterior scleritis, uveal effusion syndrome, and also sometimes in pars planitis. Another mechanism, when the patient is taking topiramate injection, it triggers an immunological response because of the protein-bound metabolites. And also we see sometimes patients who are on acetazolamide. There's a cross-reactivity, and it causes inflammation of ciliary body. And there we see anterior displacement lens iris diaphragm. Sometimes post-ocular surgery, like we have intraocular gas overfill or excessively tight buccal and aqueous misdirection, it can also cause the anterior displacement of lens iris diaphragm in these eyes. This is an interesting case of a 73-year-old patient who complained of pain and redness in the left eye for the last 2 days. And he also said there is distortion of vision in the left eye, in the left field for the last 1 month. Interestingly, 2 months back, he had a similar episode and he was diagnosed as unilateral narrow angle glaucoma and a laser PI was done. He was diabetic and hypertensive. Visual acuity was 6, and 6, and intraocular pressure was normal. So what we see here, it's a narrow angle with a laser PI done superiorly, and it's scleral congestion in the superior quadrant. But we look at the fundus, there were choroidal folds in the posterior pole. And when we did the ultrasound, it showed serous retinal and choroidal detachment with increased choroidal thickness. So what was it? OCT, it shows increased subfoveal thickness with choroidal folds and RPE folds as we see here. And then the UBM, it clears. It shows large supraciliary effusion and the ciliary body was rotated, which was the main reason of narrow angles. The patient was then treated with steroids and there was the whole thing settled, and there was probably no requirement of the laser PI in this case. Another important disease, what we all should know, is viral anterior uveitis, which is actually called a hypertensive uveitis when there is mild inflammation, raised intraocular pressure, and there is iris atrophy. The studies have shown that the prevalence of raised IOP can be 50 to 90%, whereas glaucoma, it can be 13%. We see it more commonly in VZV and cytomegalovirus as compared to HCV. And the main mechanism is trabeculitis. The eye being an immune privileged site, so the virus persists, replicates, and it just escapes the immune response. And this is just a patient to show Fuchs heterochromic iridocyclitis. We can see the Kopi nodules, iris atrophy, and stellate capes. And also we can see here in the posterior subcapsular cataract, the study in 2010 done by Ryukin et al., they detected viruses and antibodies in the aqueous humor in patients with Fuchs uveitis, and these were rubella, HSV, VZV. And another study, they had 3 patients out of 16 patients with anterior uveitis and CMV DNA, again consistent with Fuchs uveitis. And this is just to show that cytomegalovirus, anterior uveitis, if we don't recognize the mechanism of glaucoma in these uveitis and what is the cause, it can sometimes lead to severe corneal decompensation and the patient may land up in endothelial keratoplasty as we see in the first case. And the second case, again, despite that, we were treating the patient with ganciclovir and valganciclovir. The patient did develop cataract and glaucoma, and thereby leading to endothelial decompensation. And again, we had to do a tube with endothelial keratoplasty and cataract surgery. So in all, it's very important that we understand that the mechanism of glaucoma in uveitic eyes and then treat the disease appropriately. Thank you so much.
Thank you.
Thank you very much. And hopefully my internet will work this time. That was a great talk, Mamta. Thanks so much. Our next speaker is Peter McCluskey. Peter is very well known to most or all of us, but he's professor of ophthalmology at the University of Sydney and director of the Safe Sight Institute and extremely well published in uveitis. and he'll be talking to us about managing a patient with anterior segment inflammation and glaucoma, a difficult situation. Peter.
Rohit, can we play Peter's talk?
Yeah, ma'am, just a minute.
I have no relevant financial disclosures. So I think we all know that that uveitis and elevated intraocular pressure are common and a challenging problem for our patients with uveitis and other forms of inflammatory eye disease. The glaucoma is responsible for up to 15% of the severe vision loss that we see in patients with uveitis. It can be very difficult to assess and to follow our patients with elevated intraocular pressure, and indeed often the patients have significantly elevated intraocular pressure rather than true glaucoma with evidence of damage to the optic nerve, at least initially. We often tend to use arbitrary intraocular pressure levels at sort of 25 to 30 in terms of defining a significant raised pressure. It's common that there are multiple mechanisms and combined mechanisms that induce elevated intraocular pressure in glaucoma. And very importantly, steroid therapy, particularly intravitreal steroids, commonly causes significant elevation of the intraocular pressure. If elevated pressure persists, it often does cause damage to the optic nerve and visual field and often becomes a surgical problem. So, as I mentioned, elevated intraocular pressure is common. A good ballpark number to remember is it's somewhere sort of up to 20% of our patients. It's commonest in forms of inflammation that involve the drainage angle and the ciliary body. So therefore, in chronic anterior uveitis, it's a very common problem. In patients who get recurrent episodes of acute anterior uveitis, it's also quite common. But we see it in all forms of uveitis and also in scleritis. And as I mentioned earlier, steroid therapy commonly is an additional risk factor. So I mentioned that there are many different mechanisms that operate in our patients that result in increased intraocular pressure and glaucoma. And I think it's best to divide them into closed and open angle mechanisms. In patients with closed angle elevated intraocular pressure, the first thing to think about is pupil block from subclerosio and multiple posterior synechii. This is one of the commoner mechanisms that we see in angle closure. Some forms of uveitis, for example, sarcoid, commonly associated with peripheral anterior synechii, and when extensive, can also result in elevated intraocular pressure. Not commonly, but again, not uncommonly, patients with posterior uveitis, for example, VKH disease and scleritis, can get peripheral choroidal detachments and effusions. This can lead to ciliary body rotation, secondary angle closure, and glaucoma. And we, of course, should never forget aqueous misdirection, particularly in some of our uveitic patients who need drainage surgery. Aqueous misdirection can be really cause severe elevated intraocular pressure and a very important mechanism to recognize. Sorry. In patients with open angles, trabeculitis, true inflammation from their uveitis or scleritis involving the trabecular meshwork, can cause elevated intraocular pressure. Uveitic debris, cells, pigment, sometimes blood, can lead to acute angle blockage. Chronic inflammation will lead to trabecular meshwork damage and fibrosis, and this will cause elevated intraocular pressure. I've already mentioned the effects of corticosteroids on the trabecular meshwork. We also know that you can get rebound aqueous hypersecretion in some of our patients as their uveitis settles down. This can elevate the intraocular pressure, and some patients develop elevated episcleral venous pressure, and this of course can also lead to elevated pressure. It's important, as I mentioned earlier, to remember that in patients with uveitis, there can be multiple mechanisms leading to their elevated pressure. So in terms of sorting out our patients with an elevated pressure, the critical first step is determining the mechanism that's led to elevated intraocular pressure. So this means that we need a careful, detailed clinical assessment, particularly a careful slit lamp examination. This patient here with herpetic uveitis, a disciform area of keratitis, sector iris atrophy, AC cells. This is a very common phenotype of uveitis associated with elevated intraocular pressure, which can be from multiple mechanisms, but often from true trabeculitis and involvement of the disease. Gonioscopy is critically important. We can see here in this gonioscopic image, the angle is wide open, but it's densely pigmented. Again, something that we quite commonly see in patients with severe, say, herpes zoster ophthalmicus. So an important mechanism to consider. We've also, of course, got to consider, as I mentioned earlier, secondary angle closure, glaucoma from ciliary body rotation or aqueous misdirection. Also, of course, occlusio and iris bombay and angle closure. If you're not sure what's going on, most of the time there's minimal risk in doing a laser PI to see if that will relieve the angle closure. So an important series of steps to think through and to examine. Imaging can be useful, and I'll show you some imaging in a moment. After you've worked out what's going on, acutely you need to lower the intraocular pressure if it's dangerously elevated. Obviously, we need to control the uveitis, the underlying process leading to the elevated pressure. And as I mentioned earlier, surgery is often the final solution. So the sort of imaging that can be useful in this patient, it doesn't project, unfortunately, particularly well, but there's iris chafing and pigment dispersion and pigment in the angle. You can see on the image here that the edge of an intraocular lens, and on the UBM, you can see that it's subluxed out of the bag, and this is the area of iris chafe that's leading to the UGG syndrome that's causing the glaucoma. If you see a very shallow anterior chamber, particularly when it's shallow centrally, it's often the result of ciliary body engorgement rotation leading to a shallow anterior chamber different to the one in the other eye. This is a patient with severe enhancement from gadolinium, from contrast rather, in the choroid, and this is the sort of thing you might see in VKH, except obviously it would be bilateral, or in posterior scleritis or other forms of posterior uveitis. And again, imaging very helpful in sorting this out. The reason I put a CT scan here is CT scanning is more widely available than UBM, and it's a very useful investigation, particularly if you can get high resolution scans, and high resolution MRIs are also useful in just help sort out some of these patients. So after making the diagnosis, the next step is really medical control of the intraocular pressure. You need intensive topical therapy, and you can, as they say, throw the kitchen sink at the patient. Beta blockers, prostaglandin analogues, alpha agonists, topical carbonic anhydrase inhibitors. Uveitis specialists, I think we're never really afraid of using prostaglandin analogues. They're powerful drugs to decrease the intraocular pressure. And although there's always been this uncertainty about whether they can increase anterior uveitis and cause other problems acutely, their pressure lowering effects far outweigh the risk to them causing any flare of the uveitis. And a study that I was involved in many years ago showed that the risk is under 1%. So I think use them when you need them. If there's any suspicion of pupil block, make sure that you use atropine to tense up the lens iris diaphragm and help to open up the angle in secondary angle closure. Obviously, oral and intravenous Diamox are really useful medications, and occasionally we need IV mannitol. Don't use pilocarpine. I mentioned earlier that this often becomes a surgical problem. Surgery is very outside of a PI. It's extremely rarely indicated acutely in this sort of scenario I'm dealing with, but there are a number of important indications for surgery, but that's really further along in the management of most of our patients. But there will be the odd patient where we just can't control the pressure. And if the pressure stays above 40, then you really do need to acutely do some drainage surgery to settle the intraocular pressure. There are a number of surgical options. Acutely, really, it's a trabeculectomy and occasionally a glaucoma drainage device, but other speakers will talk about surgical options in detail. So I thought I'd finish off just with a case to try and bring together the elements of acutely managing a patient with severe uveitic glaucoma. So this is a patient of mine, a 60-year-old male who was referred in urgently to Sydney Eye Hospital, where I work, to the emergency department with increasing pain and rapid onset of decreased vision. 4 weeks earlier, out in the community, he'd been diagnosed with right-sided herpes zoster ophthalmicus. He had a 5-1 vesicular rash and anterior uveitis. He was treated with oral valganciclovir and Maxidex, and things were going well until this sort of sudden increase in pain and rapid decrease in vision. So when he was seen in the emergency department, vision was reduced to 6/60. The cornea, although clear, there was significantly decreased corneal sensation. The anterior chamber was deep with moderate AC cells. There was some sector iris transillumination defects, but no posterior synechia. The pupil was poorly reactive to light, mid-dilated at 5 millimeters, and there was probably a very mild RAPD to the right side. There was some, age-appropriate lens changes. And interestingly, in the fundus, there were choroidal effusions nasally and temporally, which I'll show you in a moment. So here are some images of the patient. So this shows the clear cornea, fixed dilated pupil. See some iris transillumination defects on retroillumination. The eye is very injected, and here is and it's injected pretty much 360 degrees. And focusing in on the superior temporal quadrant, you can see that there's scleritis here. Contrast this to the normal uninvolved left eye. So here are some Optos images showing the choroidal effusions, a bit more obvious on the autofluorescence, both nasally and temporally. B-scan showing grossly increased eye wall thickness and a T sign. And on a CT scan, again, showing increased eye wall thickness and more prominent anteriorly than posteriorly, which sort of fits the clinical picture that we saw, quite different appearance to the CT scan of the other eye. So our diagnosis was that this patient had panscleritis related to his earlier episode of herpes zoster ophthalmicus. Quite common for there to be a bit of a delay between the onset of the rash and the development of scleritis. There was also significant uveitis. The anterior chamber was deep, and we did perform gonioscopy. I don't have an image, unfortunately, of this patient. And so you can see that there is a little bit of pigmentation in the angle, but it's wide open. So in terms of helping us to determine likely mechanisms, the anterior segment examination reassures us that although there are choroidal detachments and there might be a tiny amount of ciliary body rotation, there's no secondary angle closure. So this isn't a mechanism. If we go back to the CT scan, the appearances in the rest of the orbit are normal. Sometimes in patients with panscleritis, you can get significant spillover into the orbit and into the orbital apex. So on occasion, you can get an orbital apex syndrome. elevated orbital venous pressures, and that can be a mechanism for the glaucoma, not in this case. So the likely mechanisms are all related to an open angle. So trabeculitis, very common in patients with herpetic uveitis and scleritis. There is some pigment dispersion that we can see clinically from the iris defects. There is significant uveitis, so likely to be a component of blockage, acute blockage of the angle. Posterior scleritis and severe panscleritis can give you elevated episcleral venous pressures, so that may be a part of a contributing mechanism here. And of course, our patient has been on topical steroids, so that may be part of the case. So what are we going to do? Two strategies that we need to apply acutely. Control the intraocular pressure, which I must admit, embarrassingly, I forgot to mention, was 48 on arrival in the emergency department. So intensive topical hypotensive agents, timolol, brimonidine, latanoprost, atropine, to make sure that there is no secondary angle closure element that's going to occur. Treat the uveitis. If necessary, use some oral Diamox, and very importantly, treat the underlying inflammation. So oral prednisolone for the scleritis, topical Maxidex for the uveitis, and a further treatment course of valacyclovir to treat the herpes zoster. And with that, that's really where we need to go to here. You know, a patient like this usually settles down quite well, and once we get the pressure down and the uveitis and scleritis controlled, it stays controlled. I can't really finish my talk in the final IUSG webinar without talking about my good friend and colleague Manfred Stewart, who sadly passed away last year. This series of webinars was largely Manfred's idea. He really twisted all of our arms to make sure that we became contributors. I was lucky enough to be on a webinar early on in the series with Manfred. I've known him for 20 years. The last time I saw him was when we all went touring in Mongolia back in 2018, and like everyone, I miss him greatly. He was a fabulous colleague and clinician scientist, an inspiring teacher, and importantly, a great life enthusiast and adventurer. And one of his aims was to visit every country in the world. He got, I think, to about country 119. So on that note, thank you so much. It's been a pleasure to have been a speaker in this webinar and in the whole course. And good night. Thanks very much, everyone.
All right. Very nice. Thank you so much, Peter. And our next speaker is Dr. Carsten Heinz, who's professor of ophthalmology at St. Franziskus Hospital in Münster, Germany. And he's going to talk about the role of laser / peripheral iridectomy, indications and considerations. Carsten?
Hello and welcome everyone. My name is Carsten Heinz. I'm working in Münster in Germany, and we do treat a lot of uveitis patients, especially children with JIA-associated uveitis. I'm very happy to participate in this uveitis webinar on uveitic glaucoma. My talk is about the medical therapy, role of laser treatment, peripheral iridectomy, and I would like to share my considerations and some indications for the treatment. The first thing is, when you talk about uveitic glaucoma, you have to think what happens and where does it happen. So when you look at the two important regions, it's the ciliary body and the anterior chamber angle, and with regard to an open angle glaucoma, you only can have a reduced IOP if you have an affected ciliary body due to the inflammation or to the detachment you will have a hypersecretion, and so you will have a reduced IOP. This is different for the anterior chamber angel. So usually if you have an increased uveitic activity, you will have an increased uveal scleral outflow, and therefore you will have the reduced IOP. On the other hand, due to a trabeculitis, which is normal in viral uveitis, due to morphological changes, which is the main reason for an elevated IOP and secondary open-angle glaucoma, or due to an occlusion, which should be happened due to debris or cells in the trabecular meshwork, you will have an elevated IOP in these eyes. The second issue is the angel closure glaucoma, which is much more rare compared to the open angel glaucoma. So what you can see in these patients that the pressure goes significantly up. This may be due to the posterior synechis. You may have peripheral anterior synechis, or you also may have a forward rotation of the ciliary body, which increases the IOP. What we do see in the elderly, that we have a forward displacement of the iris due to a thickened crystalline lens, is relatively rare in uveitis patients, but may occur in some rare cases in elderly patients. How effective can a medical therapy be in uveitic open-angle glaucoma? And this is a work we did with our patients, and we look how effective topical therapy alone can be. And you can see if you only treat them with medical therapy, you get rates of 24–26% in adults or in children. It's quite important that you can see if you have the direct way of failure going to glaucoma surgery, and the second way going into a failure if they had topical therapy combined with carbonic anhydrase inhibitors for more than 4 weeks, they also may end up in glaucoma surgery. And this figure, if you sum up these two numbers, you get really high figures, especially for the children, with 60% of children going for glaucoma surgery on the long hand, and on the other side there's only a limited number which do quite well with topical therapy alone. This is this group, and the other group who need carbonic anhydrase inhibitors for a longer period than 4 weeks. The interesting or the important question is when do we have to start therapy? So I feel it's sometimes very difficult to distinguish whether we have a manifest glaucoma or if we do have an ocular hypertension. So if you go to the Sun paper from 2005, you always will find that there was no clear definition for the ocular hypertension. So there could not be a clear limit established, which helps you to decide when you have to start. So it's very important that there are some rules you have to follow. So what we do is we do not think about starting therapy if we do see optic neuropathy. We do start if we have visual field defects, which is sometimes difficult to detect because of other complications the patients have. And we also start if we have a IOP which is above 25 on several occasions, even if we do not have an optic neuropathy. And especially in children, this is quite interesting. If you look at both eyes, you may see that the one healthy eye has no excavation, while the other one has a very mild excavation of 1.0, 1.2, which you usually would not start therapy. But in these patients, you should start, because there's a marked difference between these two eyes. Starting with medical therapy is always the first step. So in this country, in Germany, there's no topical anti-glaucomatous drug approved for uveitic glaucoma. What you usually do is that you need to combine multiple drugs to achieve the target IOP, and this means that you sometimes even use 4 different drugs to achieve this target. So this is just a brief summary of what you can do. You can use nearly everything you use also in the normal open-angle glaucoma. So starting with beta blockers, they are usually very good tolerable, but they may induce uveitis, as every drug can induce uveitis, and this is especially valid for the metoprolol medication. Carbonic anhydrase inhibitors may have an impact on the carboanhydrase of the endothelial cells, so it may worse corneal edema. So if you have severe precipitates on the back posterior side of the cornea, think about starting with something else. So the alpha agonists also do quite good, but they have often a poor local tolerance, and they also may induce uveitis. The miotics is something you should not use in uveitis patients because it dilates uveal vessels, so it enhances the inflammation, and therefore it may predispose to posterior synecdoche, and they also may accelerate the pupillary membrane formation. What we sometimes do, but you usually would like to do it only temporarily, is the use of systemic carbonic anhydrase inhibitors. You must be aware about the side effects. It's paresthesia, it's maybe a hypokalemia, and it may be an allergic reaction, which is a cross-reaction to sulfonamides. So the maximum dose should be something about 10 to 20 milligrams per kilo per day, and you should discuss this very open with all your patients. And the last medication, the last medical medication I would like to talk about are the prostaglandins, prostamides. So there was a story that these may have an impact on uveitis flare, and especially on uveitis macular edema. So with the studies which are now available, or they are already available for many years, so we do know that there's no significant increase in macular edema and in flares, and nevertheless it's primarily used in inactive uveitis patients. And there are two studies I would like to show. This is one using xylitol, it's latanoprost, compared to combination of beta blocker and carbonic anhydrase inhibitor COSOPT. And what they could see that there's a similar effect on the IOP, but they did not see any relapses of the uveitis and no macular edema development. And the same is also valid in another study done with bimatoprost, and they could not find any increased rate of uveitis relapses in these studies. The last one, which is on the horizon, or which is already approved in many countries, are the Rho kinase inhibitors. There's one study with, for me, these are preliminary data, and in this country we have the problem that the Rho kinase inhibitor is only available in combination with prostaglandin, with latanoprost. And they could show that there's a good IOP lowering effect in around about 50% of the patients. These are so-called responders, and you can see the effect in the first month. So if nothing is going to happen the first month, you can stop the treatment with the Rho kinase inhibitor, and you must be aware that many of them complain after the first few days, or within the first few days, of conjunctival hyperemia. And interestingly, it's also valid that they do not have an increased risk of uveitis relapses when they were treated with the Rho kinase inhibitor. The last slide for the medical therapy are the children. So you have to follow some special rules for children, and it's very important to follow them because some of them may have significant side effects in the children. So what we did in Germany, again, many years ago, that we try to establish a sequence of what we should use at what time. And so the recommendation was that we should start in the children with carbonic anhydrase inhibitors with no significant risk profile for the children. Beta blockers, try to use, if available, the lowest concentration you can get, but you must be aware that they may cause apnea, so it's difficult to treat children under the age of 2. The alpha agonist is very crucial not to use it in very young children, so 6, or some also say they should be 10 or even older, because it may cause central nervous side effects with hypothermia, hypotension, bradycardia, so very important. And the prostaglandins, prostamides, we recommended to use as number 4 in the sequence. And again, parasympathomimetics are of no use in uveitis. Going on with laser treatment. So YAG iridotomy is something you should use for secondary angel closure glaucoma, and the ALT, SLT, or CPC may be options for secondary open angel glaucoma in uveitis patients. Patients with acute angioglaucoma usually present with a painful eye and with relatively high IOP. So the normal approach is usually that you try to do a YAG iridotomy, and in this study from 2001 they have compared iridotomies in uveitis patients, and they found 17 failures out of 28, and in the control group there was no failure in the performed 66 iridotomies. You can see that there's a median survival rate of the iridotomies of 85 days, and the conclusion from this work was that you should do multiple iridotomies and you should try to do large iridotomies. For everybody who did it, it's especially sometimes very difficult in brown eyes, pigmented eyes, and it's often very difficult if you have done the first one to get a good, very good, or a large second one in these patients. But nevertheless, it's worth trying to perform large one and multiple iridotomies. The next study compares patients with a YAG iridotomy to patients with a surgical iridotomy. So a concern may be that there's a huge difference in patient numbers with 111 compared to 20, but they could clearly show that the functional survival time in the YAG group was comparable to the previous work, and there was a huge difference to the surgical iridectomy with a survival time of 11 years. And the paper also looked for factors or risk factors for reocclusion of the eyes, of the iridotomies, and if you have a Bombata configuration, you may end up in rapid closure if the patients are younger, and if there was inflammatory activity at the day of surgery. Another result from the iridotomy versus iridectomy study was that a huge number, around about a third, developed an optic neuropathy during the follow-up, and that round about 1/4 of the patient need another surgical IOP lowering procedure, and this was in line with a high rate of vision loss. And there's one other clinical setting I would like to draw your attention. So we often do see patients with an acute anterior uveitis with a normal or even a low IOP, and they already have a Bombata configuration of the iris. Please do not wait until the pressure goes up, because when you're going to treat the inflammation with the control of the inflammation, you will have an increase in IOP, and usually the patient will then get an acute angel closure glaucoma. So think about performing YAG iridotomy or even a surgical iridectomy if before the pressure rises in these patients. Lasers are nowadays used very often in mild glaucoma forms. Especially the ALT or SLT are common things in primary open angel glaucoma, but with regard to the uveitis patient, there's only limited data, and especially the ALT shows no valuable effect due to the destructive procedure, and it induces the inflammation, so you can conclude that it's not recommended in uveitis patients. The data on SLT are a little bit better. You have less inflammation, and it was shown in one work cited here that in patients who had a steroid-induced glaucoma and uveitis, there's potential to reduce the IOP, but still the clinical evidence is weak that you can recommend ALT or SLT in patients with secondary open angel glaucoma and uveitis. Another approach is cycloablation. So cryocoagulation is nowadays not used, or it's only used in rare cases where you have a proliferative retinal disease as well, and you would like also to cover the ciliary body. So the current approach is cyclophotocoagulation, and also with this treatment you have conflicting results, and usually it's used if nothing else is working. So for us it's normal a procedure when you did for example trabeculectomy or any shunt surgery, and all of these surgeries have already failed. So these are again data we found in JIA children, and we could see that we do need a lot of treatment in these patients. They have a good or short recovery time, which was quite good, but you need to repeat it, and usually they go up for follow-up surgery. And when we look at an endpoint, which was something about 14 months, we do have a failure of around about 70% compared to 30% with a limited success, or so they are still on eye drops to lower the IOP. We conclude or decided not to treat them with this kind of treatment anymore. Another study with another subgroup of uveitis, patients with Fuchs uveitis and glaucoma, and again cyclophotocoagulation was used as primary surgery. You can see here that they need also some more than one treatment per eye, and they have reasonable success rates with a success rate of 60% of eyes below 18 after 1 year. But as in the JIA group, these patients need additional local therapy to achieve the target IOP. So especially with the new techniques being available, cyclophotocoagulation can't be a primary surgery. The success seems to depend on the patient group and probably also on the individual experience, but nowadays it's something which is usually used as the last therapy in patients with secondary open angle glaucoma. Compared to surgical therapy in uveitic glaucoma, medical therapy and laser therapy is not so difficult, because for medical therapy, which is always a first-line therapy also in uveitic open angle glaucoma, you can nearly use all the drugs you also use in primary open angle glaucoma. Be careful with prostaglandins if you have an acute inflammation, and avoid miotics in patients with uveitis. Having in mind that there are some contraindications for the use in children, there is a recommended sequence how to use it. And if you go on to the later treatment, YAG iridotomy is something which is working, but you must be aware and you have to discuss with your patient. This is only with a limited survival time, and you should go for surgical iridectomy in most of the patients. And to sum up the laser treatment for the open angle glaucoma, there's only a limited value, and only the CPC seems to be often used as the last therapy if all other surgical therapy have failed. Thanks for your attention. I'm really sad that I can't take your question, but I'm pretty sure that the rest of the panel is happy to take your questions. Thanks.
Very good. So indeed, if you want to ask such questions, you can put it into the Q&A, and we'll try to address the questions. So our next speaker is Professor Marc de Smet, who is the founder and head of MIOS SA Lausanne and Chief Medical Officer of a company, I don't know how to pronounce it, but Precise, which makes ophthalmic robotics or is developing them. He was formerly the department head of ophthalmology at the University of Amsterdam, and he has provided a great deal of energy into our IUSG group as the treasurer previously and now as the secretary. And we're happy to have Marc speak with us about newer drugs on the horizon for uveitis and glaucoma. Marc?
Well, thank you very much. This is a kind introduction. I'm not the CMO of that company anymore, but what we'll do now is we're going to talk a little bit about newer drugs that can be available and maybe the next stage in glaucoma management. Let me see if I can share these slides correctly. Can you see the screen?
Yes, Mark.
Okay,
Yes.
very good. So these are the financial disclosures. I'd like to, first of all, dedicate this talk to Manfred Zirgut, that unfortunately passed away. And it's under his leadership and guidance and constant nagging in some ways that we got this program started, and we will continue in a new form. This is me with him in India at one point after the meeting, trying to discover a little bit more about the city. And one of the very first times that I seem to be stuck here 1 second. First times I met Manfred in one of these IOSG meetings was a long time ago in Chennai. And you can see here Manfred on the very left-hand side. Now, with regards to IOSG, I mean, uveitic glaucoma, what we need is really to be able to get new drugs, something that will allow us to be able to manage the patients that you've heard described before. And these are several of the steps that I thought might be important. Not all of it is regards to novel anti-glaucoma drugs or novel anti-inflammatory drugs. It also has to do with how we try to recognize patients early enough and manage them aggressively, because as compared to a standard uveitis patient, which Massimo has told you, they tend to be difficult to recognize, they progress more quickly, and do so with a lower pressure. Inflammation is definitely part and parcel of this process. If we're looking here at sort of a GWAS approach to looking at patients that have different forms of glaucoma, and in particular, chronic posterior angle glaucoma, many of the factors that are increased are related to, on the right-hand side, cellular movement, inflammatory response, and it also induces cell death. And if cell death is being induced, obviously, there's no potential for recovery. So let me show you a case of mine. It's a HLA-B27 patient with anterior uveitis, a 54-year-old woman. She has recurrent episodes of anterior uveitis, in response to steroids, but once you increase the steroids, according to the chart anyway, the pressure goes up. She came to me a little bit later in her course in 2019. She was started on Humira, had cataract surgery in both eyes with great results. Vision was excellent. She lives in Africa, and shortly after, in 2020, because of cost, she just stopped the Humira and continued on a chronic course of Pret Forte and Cosalt. Occasionally, she said to me later that she had a red eye, so she would increase the drops to every hour for about a week and go to her standard of care. Then she developed low back pain in 2021, went on to cyclosporin, and about 3 months later, noticed progressive pain loss in her right eye. And this is how she presents to me. Vision is hand motions in the right eye, 0.5 in the left. The IOP is only 25. The highest that I've been able to record in that eye was 30. There is, in fact, no sign of inflammation, but really, the only thing we did in her case was to remove the steroids, start her back on the Humira. The pressures went down. We were able to control the situation systemically, but obviously in the right eye, her visual field was virtually non-existent. We couldn't record it, and she's left with about half a field in the left eye. So one of the questions here is 25, you've heard before, is where you should start treatment. Probably 25 is too high for many uveitis patients. Maybe we have to start thinking about a lower threshold. And from some studies that John was involved in, the MUST trial, in the group that was not receiving the implant, patients that did not have a pressure increase over 16 had no progression to glaucoma. And maybe he can comment later in the discussion. While above that level, there was a progressive increase in the number of patients that did have glaucoma. So should 16 be our new normal for uveitis is a good question. Another patient of mine that has a cataract, macular edema, you can see here a membrane, and she is a very sensitive steroid responder. A small amount of steroids, her pressure goes up above 30. There are some visual field changes. How are we going to manage this unilateral patient but probably the best option is to go over to systemic therapy, even for unilateral disease, if surgery is going to be required. And the alternative, of course, is to consider conclusive surgical approaches that will reduce pressure at an early stage. So what about a novel anti-glaucoma medications? Well, you've already heard a little bit about the use of ROCK kinase inhibitors. This is some of the background data in animals in a model of inflammation that has been induced using LPS. And in fact, if you're using a ROCK kinase inhibitor, you find that you do not develop any significant cells in the anterior chamber. And a much reduced degree of leakage. And this has to do with the fact that you're blocking pro-inflammatory cytokines, in particular IL-1 and IL-6. You have a reduction in TNF that is being produced, as well as a blockage of MCP-1. And most interesting, maybe beyond just the fact that you're able to reduce its inflammatory factors, is that ICAM1 is reduced, and so you get less also cells that are able to fix themselves onto the endothelium and then migrate into the tissue. So ROCK kinase inhibitors, even though they've been brought into the market to treat glaucoma, and yes, they do cause some vessel increase in conjunctival, let's say, congestion. Some of the later studies have shown, in fact, that this is very tolerable and in majority of cases will be accepted. It does seem to also have a very potent anti-inflammatory response. And so the same study you saw before, and this is a pilot study, obviously. There are 2 other studies in the literature that are similar, with similar results. In a population of patients with uveitis that are receiving multiple and varied drops to control their intraocular pressure, you find that you're able to reduce that intraocular pressure in about 30% of patients in a significant way, with a reduction of 30% or more, and in about 50% of patients with about 10%. And you can see here the degree of reduction. So it's not probably sufficient for a person that's at 25, but if the pressure is lower, let's say about 18 or 19, it may be in fact a very good drug that might combine 2 things, a reduction of inflammation as well as intraocular pressure. And as mentioned earlier, you usually see the result early rather than late. Not all patients will respond, but those that do probably would do well on this drug or the drug combination Rocaina that contains also an antennaprost or prostaglandin. What about trying to have a novel mechanism, something that would be anti-inflammatory and would not raise intraocular pressure? That would, of course, be the holy grail of what we want to do. And so to this end, I'll speak more about a new drug that isn't on the market yet. It's still under investigation. It's called Dasdotuftide. But it is a covalent link between 2 molecules, the phosphorus and the tufsin. Phosphorus is in fact a product that is produced by worms that are and helps them to maintain their immunosuppression within people that are infected. If you look throughout the world, usually where there are helminthic infections, there are a lot less autoimmune diseases. So this seems to be a very potent molecule. Tufsin is an immune-enhancing tetrapeptide, something that is produced in the spleen as it breaks down immunoglobulins, particularly immunoglobulin G. So the combination of the 2 becomes quite interesting because it increases anti-inflammatory cytokines, it decreases the inflammatory ones. If you look at this list here, interferon, TNF, IL-1. And what it does also is create a shift in the macrophage profile from a type 1 to a type 2, which is more, anti-inflammatory. And it also reduces NFKB production. It also has actions in other areas. All of these altogether suggest that it might be a very nice medication to control inflammation. And since it does not seem to have any effect on intraocular pressure. Maybe even more interesting is that the company Tarsier that is trying to develop this has produced 2 formulations, TRS-01 that would be in the form of eye drops placed on the eye surface to try and control anterior segment inflammation, and TRS-02, which they have not really started to develop, but where they'll be aiming more at posterior disease by doing intraocular injections. So most of the rest of the talk will be about TRS-01. The initial study, the pivotal phase 2A, consisted of patients that had anterior chamber inflammation. The majority of these were patients that had post-cataract inflammation. There was, in fact, a significant reduction in the amount of cells that are present inside the eye. And quite a few were able to reach a grade 0 within 3 or 4 weeks, more so than was achievable by using topical steroids. There was no pain associated with the use of these drops or irritation. And in fact, although the signal was not looking for that, there was in fact no increase in intraocular pressure. So what followed was a TRS-4 vision study with the TRS-01. It's a bit confusing when you look at these two terms, but it's just, I think, in order to be able to indicate the importance of their concept. This was a non-inferiority study that looked compared to standard of care with Pret Forte. The primary endpoint was looking for grade 0 in terms of cells at about 28 days with active non-infectious anterior uveitis. And these included also patients that had glaucoma and potentially also some children. Multi-center trial in the US and Europe. You can see the distribution of the patients, both with TRS-01 as well as steroids. It's a 2-for-1, more or less. The balance was pretty good, except for the fact that there may be more women that were being treated with the drug as compared to men in the steroid group. In order to assess the anterior chamber, a special scale was developed, which is partially shown here on the left-hand side, is better shown here. It's in fact based on being able to compare the cells in the anterior chamber with these diagrams that are present here on the right that were computer generated. And instead of trying to count cells, you're trying to look at their stacking or distribution within the anterior chamber, which when this was tested experimentally is a much better way of trying to assess the amount of inflammation that is present in the anterior chamber. The results that were found indicate that, at least in this rather small study, for the primary endpoint that was chosen, that is being able to reach a grade of 0, starting with a grade of 2, the TRS-01 did not do quite as well as steroids. It didn't reach its primary endpoint, but it may also be a question of the number of cases that were looked at. What was interesting, though, is if you stop the medication in both of these eyes and you look at a patient 2 weeks later, is to look at the number of rebound. That is to say, patients that, in fact, did not rebound in terms of inflammation. And there you find that the patients that were treated with TRS-01 had less rebound than the ones that had been treated with the corticosteroids. Also, if you look at whether there was any increase in intraocular pressure, there was in fact very little increase in intraocular pressure, certainly none above 10 using this new compound as compared to steroids, where 13% had an increase. And if you look at the 5 millimeter increase at any point in the follow-up, 9% did so using this new drop, TRS-01, as compared to corticosteroids, where 23% had an increase. So that if you combine and you create a sort of a combined score that looks at the patients that have total resolution of information, a prolonged effect, and a stable IOP, which is, of course, a sub-analysis, and one has always to be very careful with this, then we do find that TRS-01 is doing better than the corticosteroids. And this is obviously also quite significant for us. If we are going to do a treatment, you want to be able to stop it at some point, and you would prefer that these patients don't have a pressure increase. If we look specifically at those patients that had a history of uveitic glaucoma, and we're now looking at a small group, this is only 12 with TRS-01 and 11 with the steroids. Here, there is a significant difference in terms of, in orange, the ones that are successfully treated with this combined approach using TRS-01 as compared to steroids. Now, as many drugs, this one, when you look at it with regards to factors, melanin binding, it does bind to melanin. And so patients that have a pigmented iris tend to have more of the drug that is bioavailable and it stays around for a longer period of time. And this is something that can be also seen here with regards to TRS-01. The response rate is better in patients that have dark eyes and less so for patients that have blue eyes. And the treatment here was quite, it was limited to one dosage, 1%. It's what was found from the original study. And it was also only 4 times a day. And it's rare that we start treating patients that have an ocular inflammation by just giving drops 4 times a day. If we look at adverse events, they were rather limited. If you look, they're quite balanced on both sides. A little bit of punctate keratitis, but only 1% as compared to what was seen, or 2% as compared to what was seen with steroids. But there was nothing really of significance here. So in the end, if we look at how can we optimize treatment, where should we go forward? Well, one is maybe we have to redefine what our threshold for the management of uveitis is in our uveitis patient. We need more data for this, but certainly there are cases like the one I've shown you, where I think our current approach is not sufficient. Aggressive management is probably necessary. You've heard about the use of systemic therapy from some of the previous speakers, and I certainly think it's necessary both in the acute surgical setting in some patients and maybe also in those that seem to be resistant. We should certainly consider doing this since we have some good drugs that can control inflammation, and sometimes that is all that needs to be done. Rho kinase inhibition seems to be a very promising approach, and hopefully the further studies that will be done with the dasotaftide will be positive and encouraging. This would be the first drug that is allowing us to control inflammation without having a pressure, intraocular pressure increase in our uveitis patients. Thank you.
Thank you very much, Mark. And so that was very interesting. So we really appreciate you giving the talk. As a little interlude before our last talk, as was mentioned before, this is going to be our last webinar, but we're moving on to another curriculum, and Alejandra De La Torre is going to just introduce us to that. Can we have Alejandra's screen? I think you're still muted, Alejandra.
Yeah. I will share. Sorry. Thank you, John, and thank you, Vishali. Upon completing the IUSG webinar program today, we are looking to begin a new educational format, Uveitis Ground Rounds, which will be launched on January 2024. The idea is to illustrate significant uveitis forms in a case-based format. These are the proposed dates and topics. There will be 10 sessions presented every second Saturday of the month, starting on January 13 to December 14, 2024. Each session will have the following structure. First, the case presentations. There will be 3 types of cases: basic, intermediate, and advanced cases. Then a thematic lecture, and finally, a general wrap-up discussion. After all the ground rounds, we would like to compile a book where each ground round will constitute 1 chapter, resulting in a total of 10 chapters. We look forward to your active participation. And we hope this new way to presenting IUSG webinars will be as successful as the 30 webinars we have completed today. Thanks to Manfred, who started them, and thanks to Vishali for continuing them and having the enthusiasm to continue growing the participation of colleagues in the IUSG worldwide. Thank you very much.
Very good. And I wasn't sure, Vitaly, if you wanted to share about the advanced course. Do you want to go ahead with that?
Yes, I think many of you would have received it by email, but in case we do have, I think now not 15, but very few slots are left over for advanced course in uveitis, which will be held in the memory of our friend Manfred at Chandigarh, India, between 25th to 28th January 2024. It will more or less cover everything about uveitis, including hands-on training on some of the imaging, injections, and steroid implants. If you need any more information, please get in touch with me directly. Thank you. Thank you, John.
Thank you kindly. So that should be a great opportunity. All right, so our last lecturer, Massimo, has kindly agreed to present two of them, and he's now going to talk about surgical management of glaucoma and uveitis, which we've heard is a unfortunately frequent situation. Thank you kindly, Massimo.
Thank you very much. Can you see my desktop?
Yes.
Okay. So hi again, everybody. I hope my voice doesn't bore you too much. And I cannot go. Okay. So before addressing the surgical option for uveitic glaucoma, it is important to remember that almost 30% of patients with uveitis and ocular hypertension or glaucoma are not controlled by medical therapy, and they need laser therapy or surgery. But which are the peculiar characteristics of these patients? There are several. The first is young age. In young people, you can expect a faster healing of the after the surgical procedure, and this might be a big problem with correlation with the risk failure of your filtering surgery. Second peculiar aspect is log life expectancy, and as we will see later, most of the surgical approach to uveitic glaucoma might have over time very severe complication, and this should be taken in proper considerations. The third is a previous prolonged therapy. So many of our patients with uveitis are treated initially with a medical therapy, and therefore this medical therapy can cause a macrophagic activation at the level of the conjunctiva. And this is a problem because the macrophagic activation can close your filtering procedure in a very short period of time. The fourth is the increased post-op inflammations. We will see that it is important to control inflammation pre-op and even post-op. And if we expect any increase in intraocular inflammation in patients after any kind of surgery, this is the same in glaucoma surgery. Post-op inflammation means a risk for surgical failure. Additionally, we can have a post-operative complication related to the surgery you have done, and this might add to the usual complications that uveitic patients can have. And also, patients are very young. During their life, they might need other surgery, and all the other surgery, especially cataract surgery, can compromise the results of your glaucoma surgery. So the ideal preparative condition is to have a patient to uveitis for a minimum of 3 months, but this is not practical in some patients when, as you have heard from Peter, you have a very high intraocular pressure, higher than 30 or 40 millimeter of mercury or maximum tolerated medical therapy, and you cannot wait for resolution of inflammation because the patient, for instance, is losing his visual field. So if you have preoperative inflammation, you would expect a possible exacerbation of inflammation after surgery, and this will mean an accelerated scarring response that drive you to a surgical failure. Additionally, this is a series of mine of patients who have been operated on for uveitic glaucoma, and we have found that the age of onset at uveitis, the mean age of onset is around 33 years old. The age at glaucoma initiation of the therapy is 37, almost 38. So the mean interval between uveitis onset and the need for a glaucoma, anti-glaucoma therapy is 4 years. And the mean interval between the start of a glaucoma therapy to the surgery is additionally 5 years. And finally, you can find some patients with uveitic glaucoma who need surgery with a 20/20 visual acuity and more or less normal visual field. So if you see at the visual field in the upper side of these slides, there is no question that he or she needs a glaucoma surgery, but it's quite difficult to suggest a surgery in a patient, in a very young patients with little or no visual field changes and high intraocular pressure and 20/20 visual acuity. So from these perspectives, all considering, we have a great Hamlet duct. So to do early surgery, which can be related to a less conjunctival fibrosis because we have used our medications for a limited period of time. So theoretically, we can have an higher success rate. On the other hand, we have also a longer life expectancy. And as we will see later, the complication can arise even long-term in patients submitted to surgery for uveitic glaucoma. The opposite is to do a less surgery, that is to defer the surgery until all the medication has been experienced and failed. So in such a case, you can have more conjunctival fibrosis with a theoretical lower success rate, but on the other hand, you can have a decreased risk of post-op complications. We now are approaching the most used technique for the treatment of uveitic glaucoma, that are trabeculectomy, deep sclerectomy. I will speak a little bit about not the mix, but the minimal invasive devices, implant and the drainage device. I would like to see that most of the study are not comparative, so it's very difficult to draw definite conclusion, and as we will see, on the best therapeutic choice for our patients. What is clear, should be clear, that we have a risk factor for failure. There are male sex age lower than 45 years old, prolonged postoperative inflammations, and there are papers just addressing the role of granulomatous uveitis as a risk factor, and others with non-granulomatous uveitis. So I can conclude that all the type of uveitis is a risk factor for a surgical failure, and even the same is for cataract operation before or after glaucoma surgery. I will not go into details of the technical, the surgical technique, because they are exactly the same that you can do in patients with other forms of glaucoma. I would like to just say that it is impossible not to use mitomycin C or 5-FU in the trabeculectomy group of patients. The success rate for trabeculectomy, either complete or qualified, range between 70 to 92% at 12 or 36 months. And in TRAB, as well as in all the other procedures, the success rate decreases over time. This is very important because we are facing with a very young patient. Which are the cause of failure? One single episode of uveitic relapse carry a surgical failure, increase the surgical failures by 5-folds. While in eyes with inactive uveitis, the success rate decreases for postoperative hypotony, that is very important, and usually is one of the usual findings after the operation, ifema and bleb leak. Which are the complications? I've divided them into early complications, medium term, and late complications. The most common early complication after trabeculectomy is post-op hypotony, shallow anterior chamber, and choroidal detachment, as well as bleb leaks and ifema. That is particularly important, for example, in patients with Fuchs uveitis, which usually shows the hamster sign that means bleeding of the anterior chamber after even a single paracentesis. In the medium term and the late term, of course, you have bleb leaks and blebitis because of the conjunctiva, the way of the conjunctiva will heal after the surgical procedure. But most important is the cataract progression or onset that has been found in 20 to 45% of patients submitted to trabeculectomy in patients with uveitis. So in order to try to lower the risk of post-op hypotony and to lower the post-op inflammation, deep sclerectomy has been suggested for the treatment of uveitic patients. In such a surgical procedure, you do not need to do iridectomy and anterior chamber penetration. And the question is, you have to use, of course, the mitomycin C also in these patients, or 5-FU after the procedure. And the success rate has been demonstrated that is quite the same as in trabeculectomy. You may need, and we will see some more postoperative maneuver just to maintain the intraocular pressure under control. And this is the results of the first study comparing trabeculectomy, deep sclerectomy in patients with uveitis. As you can see, the IOP values and the probability of success at 12 months are exactly the same. You need a more postoperative adjustment to lower IOP in patients with deep sclerectomy, but in those patients, we also have a lower grade, lower amount of inflammation at day 7 after surgery. So I don't want to go into detail of some other procedures such as canaloplasty and gonioscopy-assisted transluminal trabeculotomy, because there are very few reports on this type of surgery that can be used essentially the gonioscopy in juvenile idiopathic arthritis and the canaloplasty in older patients. But I would like to focus the attention on this minimal invasive device implant. There are the Express, the Xen, and the PreserFlow. The Express is essential a piece of steel that has been placed under a scleral flap, and it has a very little penetration in anterior chamber. It can provoke during time scleral erosion and endothelial cell loss or iritis if it is not well positioned in anterior chamber. All of these procedures are filtering procedures, so the theoretical possibility of blebitis exists for all of them. The XZ gel is a porcine-derived polymer which can be introduced through a paracentesis and usually combined to cataract extraction or transconjunctivally, either with a cut or with uncut conjunctiva. It has been demonstrated that it can provoke a transient IOP elevation, so it may know the proper way to approach patients with a very damaged visual field, and blebitis, we have already spoken about this. And the last one is the PreserFlow. This is there is a little bit difference between this one and the others because it is a very long piece of material. This is polymer that the same structure as the cardiac stent, so it should be associated with a very good biocompatibility. It is so long, 8.5 millimeters, and this is theoretically it may drive the aqueous humor far away from the limbus where the stem cells are located and where the scarring process should be lower than around the limbus. It is important to remember that all these devices have been associated with a reduction in intraocular pressure approximately to 30% from baseline. And for medical legal problems, you should keep in mind that the data sheet of the Express and the PreserFlow clearly indicate that they are contraindicated in patients with uveitis, while for the Xen implant, it has been written that it is contraindicated in active uveitis. And this is an example on what can happen with the PreserFlow implant, where you can have an erosion of the scleral flap with exposure of the Express implant. If you need to reach very low pressure, you can use a drainage devices, and these are the four most used. It is the Hamed, is the only valved device, the Bevet, the Molteno, and the more recently Pool device. They differ for the size of the plate, for the diameter of the tube, but essentially the rationale to use this device is to bring the aqueous outflow far away from the limbus, 8, 9, 10 millimeters far away from the limbus. They have been found to provoke an important reduction and sustained reduction of intraocular pressure over time, maybe better than trabeculectomy. The problem is that they may carry very long-term complications, and it is difficult to decide which is the best choice for primary surgery in patients with uveitis. These are the complications. You can have early complication. The most frightening is post-op hypotony. That is usually to avoid this complication in the Bevet implant. You can just put a Prolin suture inside the tube and some other suture outside of the tube in order to decrease the outflow, at least in the first weeks post-op. Inflammation also can occur, and tube occlusion as well. While in long term, as you can see in this picture, you can have a scleral conjunctival erosion and the endothelial cell loss, inflammation again, and tube occlusion. So the last two questions about the best choice for patients with uveitis. So should we treat them with an implant of a device, in such a case, a Hamed valve, or a trabeculectomy? As you can see in this graph, the decrease in intraocular pressure is almost the same, except for the results at month 3, when trabeculectomy seems to be more effective than the Hamed valve. The probability of success is exactly the same, around 82% at 12 months. But in the Hamed valve, we have a significant increase of needs for medical therapy to control the IOP. A complex success at 12 months in the Hamed valve is 12, in the trabeculectomy is 15, and the difference is statistically significant, although the failure is exactly the same at 12 months. In both groups, the authors have observed a decreased inflammation that is significantly only in Hamed patients, while in Hamed patients, there is also a significant reduction of corneal endothelial cells, and this may be of importance in very young patients with a long life expectancy. So the final question is, should we go to a combined surgery, considering that cataract has been associated and has been found in 20 to 45% of patients after trabeculectomy, or should we perform for the first time and standalone surgery? And the results come, the answers comes from the IRIS registry, with a huge number of eyes included, and they have demonstrated that the reoperation rate is higher in patients with a TRAB standalone procedure compared to TRAB plus phacoemulsification and IOL implantations, although a greater IOP reduction is found in the standalone trabeculectomy versus the combined surgery. And exactly the same results can be found in patients with an implant of glaucoma drainage device, 7.8% operation rate at 3 years, 5.4 at with the combined procedure, and again, a greater IOP reduction in the standalone surgery for glaucoma. The complication rate at final follow-up, nevertheless, are lower in the trabeculate room compared to the glaucoma draining device. So, in conclusion, which is the best surgical option for uveitic glaucoma? Many issues has arisen during these presentations, and many complications should be considered even long-term. So I would like to say that the best surgical option for uveitic glaucoma is to try to avoid surgery. Nevertheless, as you can remember from the previous presentations, many of our patients, if you follow up them for more than 5 and up to 10 years or higher, will develop an increase in intraocular pressure. And if you need surgery, you have to consider any individualized approach to the patients, considering the age of the patients, status of the lens, status of the corneal endothelium, number of years on medical therapy, and the condition of the conjunctiva. But if surgery is needed, you have to remember that uveitic glaucoma is perhaps the worst type of glaucoma to address surgically. Pre and post-op control of inflammation is mandatory. The target IOP is very difficult to define. Surgery can fail over time. It may be necessary to maintain a medical therapy. Complication can arise even long-term, and regular follow-up is mandatory all life long. And this means that because uveitic patients are usually very young, they will maintain with their condition even after your retirement. So the most important thing, I think, is to train someone who can follow your path. Thank you very much indeed for your kind attention.
Thank you. Thank you, Massimo. So we have just 3 minutes left. So I'm going to ask each one of you a question before we wind up. So I will begin with Mark. So Massimo, can you please stop sharing? So Mark, here is the question for you. We heard that we have to control glaucoma and we can do laser iridotomy, or peripheral iridectomy. Even okay. We heard the glaucoma needs to be controlled even in the presence of active inflammation. Can you hear?
I can hear now. Can you just repeat the question, please?
Yeah. We heard that glaucoma needs to be managed even in the presence of active inflammation, and you do laser or surgical iridectomy. So my question to you, like laser in presence of inflammation, how successful it is that, it closes in next 2 days, the laser iridotomy. So what is your experience?
My experience is similar. If there is an increase in pressure and you have a uveitis, you have to try and control the uveitis as much as possible before. This is part of the reason I'm arguing we should go to systemic therapy and not necessarily just steroids. If we use anti-TNF agents, even if it's for a short period of time, and short, of course, for these kind of drugs, maybe 2 months of treatment before we can really go on. And so we've heard all the armamentarium from Peter that could be used in terms of these drugs to try and reduce the pressure until surgery can be done. And I think Massimo made a very good argument also, is that it's not just the surgery and the immediate reduction in pressure that is important, it's the long run. Having said that, if you have a patient that really has high pressure, nothing seems to work, you can't give other systemic therapy, maybe what you have to do is to consider doing the laser treatment to reduce the pressure during the acute event so that you reduce the inflammation that is even due to the increase in pressure. That gives you more time to be able to control the uveitis part and to find a more definitive way of being able to treat the patient long term. And maybe you won't need more invasive surgery for a long period of time. So I think it's a complex issue. Each of these cases should probably be really seen by a uveitis expert and somebody who understands glaucoma as well as Massimo in order to come for the best therapy.
Thank you. So Mamta, there is a question for you from Sonia that in patient with Fuchs uveitis, glaucoma is mainly severe, which makes surgery with drainage device indicated. Do you agree?
I would say this is like Fuchs is basically a very benign inflammation. So again, we are not really worried about the inflammation in these eyes. So if we are not able to control it with the medication, then of course surgery comes down the list. But again, it's not never. I don't think that comes very top on the list. So we have good amount of drugs now for controlling the pressures. So my approach will be like that. If the patient is not able to control with the drugs, then surgery. Yes.
And you are a cataract surgeon, and Massimo showed that both cataract combined with glaucoma works very well. So what is your practical approach, and what are the pros and the cons of doing combined surgery versus only glaucoma surgery?
I agree with it actually. In our practice also, if we are planning a cataract surgery and then we send the patient across glaucoma and they feel now the patient is on maximum medication, so the threshold to go for a combined surgery is low for both of us. So we let them do and then we control the inflammation. And more so actually in these eyes, sometimes we feel we don't even need the systemic steroid cover because it's only the topicals, it's basically the inflammation, and we can actually manage it with only the topicals in the post-operative period, because a steroid response again goes against for glaucoma. So the threshold for a combined surgery is way low. We just go for a combined surgery.
Thank you. And Massimo, there is a question from Dr. Demetti, who's saying that if you perform YAG PI, how many PIs would you recommend? And will you increase local steroids when you do this procedure?
Well, I don't like to do YAG PI in patients with uveitis. I go straight for a surgical iridectomy because you can use your time and you can just make more severe the inflammation with that procedure, because you need at least 3 to 4. It depends on the color of the iris, of course. This is first, because you need much more energy in brown color instead of light color of the iris. So this is another issue. The other issue, you can have also a iris Bombay. But if the color of the eyes is blue or green, you can just put only one iridotomy in those patients, because the stroma of the iris is very light, so it's not so strong as the brown iris. So it depends. Generally speaking, I think that if you would like to go with more success in your approach, you should take the patients into the operating room and 3 minutes iridectomy, and that's all, and it will finish for life.
And also when you are doing peripheral iridectomy, if you have facilities, it's good idea to save the sample and get whatever analysis you want from the aqueous fluid as well as from the iris sample, because that might help in overall making the diagnosis. John, there is a question for you. Are you there?
Yes.
Yes. Mark said beautifully that whenever you are suspecting and when you know it's happening, shift to anti-TNFs and all, because you know you will not be able to give steroids for whatever reasons. Now, you are practicing in an area where you still would have to depend on steroids, local or systemic. Now, how do you deal with this situation? Do you go in for an early surgical option, then medical, or how does it work for you?
Well, it depends how high the pressure is. If it's extraordinarily high, then we would do early surgery. But I do try to manipulate between topical and oral steroids in people that seem to be very sensitive. And I do have success sometimes with low-dose oral steroids working and not causing a high IOP. I presume that their level in the anterior chamber angle is very little, whereas the inflammatory cells can probably be treated in the systemic circulation. And so it provides, I think, an advantage in avoiding IOP spikes. So I try that.
But
Taking
I-
methotrexate or azathioprine, it takes too long.
But following biologics, my impression is that in children, the incidences glaucoma has really gone down if you start anti-TNF very early in the course of the disease. So last opinion I would like on this by our panelist. That would be the last one. Yes, Massimo, begin with you.
Well, the uveitic glaucoma in children is very, very difficult to manage because we have to think about 70 to 8 years life expectancy in those children. So I would suggest, of course, to treat the uveitis properly with all the kind of immunosuppressive before going to the operating room. And I would like to delay the surgery because I think that the younger is the patient, the highest is the probability of a surgical failure. But in some cases you have to do, and maybe I would suggest not to do immediately to a glaucoma drainage device, but to try as a first choice a deep sclerectomy that is much less invasive than the placement on a glaucoma drainage device, because the cell loss in these patients will appear after 20 or 30 years, even after the implantation. So be careful. You should be keep in mind the long life expectancy of these patients and to try to avoid any complication long term.
Mamta?
I completely agree that the glaucoma surgery, it should be very down on the list. And it's really important to control the whole inflammation. And now that we know that GIA works well with biologics, so I think we should try to control the inflammation and then take the surgical option quite down the list. I too agree.
So Mark, there is last question for you from Sonia, that glaucoma and CMV anterior uveitis. Would you do straight away surgery?
No, I would try to treat first with antivirals as much as possible and try to control with other drops. And if you can get to the right dosage, I would even check the levels inside the serum. Not everybody absorbs it quite as well, the antiviral, and that's really key if you want to reduce the inflammation. And if it's been around for a long time, you have to expect that it's going to take longer to control. But if nothing else works, yes, I think that remains an option. Coming back maybe to the children, I think if you're seeing glaucoma in your child, you're not treating enough. The glaucoma in this case, to me, is a fibrotic process. It means that the inflammation is there. So if you can't control the pressure with whatever treatment, you've got to intensify it. And in most cases, then you can avoid doing surgery. And if you have to put a drainage device because of their age, I would also, of course, I'm a vitreoretinal surgeon, as you are, Vishali, but I would do a vitrectomy and I would put the end of that tube in the vitreous cavity because you reduce significantly the loss of endothelial cells, and it often is better at controlling intraocular pressure.
Yeah.
So Mamta, anything, or we can wind up?
I think I will also like to add, reiterate that glaucoma surgery is the threshold by glaucoma surgeons is very low because they see the hypertensive uveitis in a patient with viral uveitis, not just CMV, but HSV and VZV. But it's very important to identify the cause, even if it's the aqueous is negative, which most of the time we do get that the DNA is negative PCR. But I think controlling even presumptively with anti-inflammatory and antiviral is very important. And in my practice, it's like an education of the glaucoma specialist that we do not need the glaucoma surgery. We can manage with anti-glaucoma medicines and antiviral. So just start Valcivir, Valganciclovir, even if it is negative. But we can avoid the transplants. And this is like the slides I showed. There was the cases where they were just wanting to do the glaucoma surgery, and we took it and then we started on antivirals. So I think the glaucoma surgery in herpetic uveitis should be really down. We can really avoid these traps and AGVs in these eyes. That is my message for that.
Yeah, in fact, in my opinion, in my experience, sometimes they have glaucoma surgery and the pressure remains high. And until you treat with an antiviral, that's when the pressure comes down. So even glaucoma surgery in that setting doesn't help.
And it's unilateral hypertensive uveitis is really something which everybody, like, we educate our residents and fellows that this is something you have to think about antivirals in these eyes.
I was going to comment that in terms of combining with cataract surgery, I think I would be less inclined to do that if I was having to operate for high IOP while the eye's hot, like if it's sort of a disastrous, intractable elevation. Whereas if it's quiet for some time, probably the 3-month rule might be considered, then I would feel much happier combining them.
Thank you. With this, I would like to thank you all and IUSG and all of you. With the help of all our members, each one of them, it was possible to do 30 webinars, continue legacy of Manfred and fulfill what he had started. And it required lots and lots of contribution from all our IUSG members who have participated in every possible way, devoted their times month after month. And all these webinars are available on IUSG website for non-members. So anybody wants to revisit them anytime, welcome to do. And very soon we will be starting to imply this knowledge into clinical practice by starting the grand rounds, where you can ask any questions related to the application of these knowledge in the clinical practice. Wishing you all a very, very happy 2024, because we are going to meet you all in the next year now, and you will receive all the communication on the emails that you have used to register. In case your email has changed, please contact Mark, Massimo, or myself anytime. We are always available. Thank you very much.
Thank you so much.
Thank you.
Thank you. Bye.
Bye.
Bye-bye. Very, very nice, all of these talks.
Thank you. Thank you. Bye, Alejandro.